if you give a patient zero point 0.5 nanograms of this drug per milliliter of blood, you might actually keep them out of the hospital, vastly improve their quality of life.
Right, but if that level creeps up to, like, 1.2 nanograms, you might kill them?
Yeah. Today, we are looking at the terrifying math of digoxin.
It really is the ultimate narrow therapeutic index drug, NTI. The margin for error isn't just thin. I mean, it is practically invisible.
And yet, it's one of the oldest medications that is still actively prescribed in modern cardiology.
It is, yeah.
Which is exactly why we're dedicating this entire deep dive to decoding it. Because if you are prepping for nursing boards, or you're managing medications in an ICU, or, you're just fascinated by the extremes of human pharmacology, this drug is constantly popping up.
Absolutely.
So we're going to break down how it forcefully rewires the heart's cellular machinery, the critical lab values that actually predict its toxicity, and the major misconceptions that trip up even really seasoned medical professionals.
But to understand why a fraction of a nanogram dictates life or death today, you kind of have to realize this exact same tightrope was being walked 250 years ago.
Yeah, I was looking at this timeline, and it is just wild to me.
Right.
We have to travel back to 1775 to this physician and botanist named William Withering in Birmingham, England. He was called in to treat a patient suffering from dropsy?
Dropsy, yeah.
Yeah.
It's such an archaic, haunting word.
It really paints a picture. Today, we'd call it severe fluid retention from heart failure.
Right,
The
exactly.
patient is essentially drowning from the inside because their heart just cannot pump fluid effectively through the body.
And the standard medical treatments of the 18th century were just completely failing this patient. But they were also taking this folk remedy.
The family recipe.
Yeah, it's this muddy, complex mixture of more than 20 different herbs.
Yeah.
Just a recipe passed down from an elderly Shropshire herbalist who history sometimes remembers as Mother Hutton.
And because Withering was a trained botanist, he didn't just dismiss the sludge, right?
No, he didn't. He analyzed it. And he suspected that out of those 20 plants, one single ingredient was doing all the heavy medical lifting.
Which was Digitalis purpurea, right? The common foxglove plant.
Exactly. So he isolated the foxglove and spent the next 10 years conducting these systematic clinical trials on his patients.
Which is incredible for the 1700s.
It really is. It all culminated in his 1785 book, An Account of the Foxglove. And that text is considered a foundational pillar of clinical pharmacology.
Because he was systematically tracking dose titration.
Yes, he wasn't just, handing them the plan. He was methodically figuring out the exact amount needed to trigger a physical response.
Wait, so let me ask you this. My initial assumption when reading about historical medicine is always that, they thought they'd found a miracle cure and then they only realized it was a deadly poison like decades later.
Oh no, not with this.
So he knew.
Yeah, Withering actually documented the toxicity from day one. He explicitly warned that pushing the dose even slightly too high caused, violent vomiting, bizarre visual disturbances, and a really slow, highly irregular pulse.
Wow. So he recognized the double-edged sword immediately.
He did. He knew this plant had a power over the cardiac system, unlike anything else in the known world. But, he also saw how easily it could turn lethal.
Right. He meticulously documented what the drug did and the exact signs that you'd given too much. But the actual black box of the cellular machinery was totally hidden from him.
Completely hidden.
Yeah.
They had no idea how it worked.
Yeah, because the active compound itself, digoxin, which actually comes from a related plant, Digitalis lanata, the woolly foxglove, that wasn't chemically isolated until the 1930s.
Right. And the mechanism of action wasn't even figured out until the mid-20th century.
So for 150 years, doctors were prescribing this incredibly potent, dangerous drug purely based on empirical observation.
Yeah, they could see the outcome, but the biological engine driving that outcome was just a complete mystery.
Okay, so let's open up that black box for the listener. From first principles, I want to really understand the physical mechanism here. How exactly does this molecule force a failing heart to pump harder?
Well, we have to look at the electrochemical gradient of a single heart muscle cell.
Okay.
Every cardiac cell has a pump on its outer membrane called the sodium-potassium ATPase pump.
The ET-PACE pump, right?
Yeah, and its entire existence is dedicated to using cellular energy ATP to continuously pump sodium out of the cell and pull potassium inside.
So it's maintaining a very steep concentration gradient.
Exactly. So digoxin comes along, finds that specific pump, binds directly to it, and just completely inhibits its function.
It just jams the
It
machinery.
completely shuts it down, yeah.
Okay, so to make sure this sticks, let me try mapping this onto a physical space.
Okay, let's hear it.
Imagine the heart cell is like a highly exclusive, incredibly crowded nightclub.
Oh, I like this.
Right, so the main exit door, the one everyone uses to leave the club, is that sodium pump. Digoxin is a rogue bouncer who just suddenly barricades that main exit. Okay.
Now, the regular patrons, the sodium, are trapped inside, and the room is just getting totally packed.
That is actually the perfect setup because the cell has another door, a secondary transporter called the sodium-calcium exchanger, and the situation gets even more chaotic because of it.
Because that secondary door relies on the flow of the main door.
Yes, exactly. The secondary exchanger uses the natural outward flow of sodium to power its own job, which is to pump calcium out of the cell.
Ah.
But digoxin has ruined the sodium gradient. The main door is jammed, the sodium is backed up, so the secondary exchanger completely stalls.
It has no power.
Right. And the end result is that intracellular calcium levels begin to rise drastically.
Okay, going back to the nightclub analogy, because the main exit is blocked, the VIP section, the calcium, also can't get out through their special side door.
Right, they're stuck.
So all these highly energetic VIP calcium molecules are now stranded on the dance floor.
And calcium is the direct biological trigger for muscle fiber contraction.
Wow. Okay. So having all that extra calcium trapped inside the cell means the physical contraction of the muscle fibers becomes much, much more intense. We call that a positive inotropic effect.
So the failing heart muscle is basically forced to squeeze with significantly more force.
Yeah. It's a massive rave on a cellular level.
But forcing the heart to squeeze harder is only half of the drug's mechanism, right? Because it also hits the brakes on the heart rate.
It does. Separately from the muscle contraction, digoxin increases vagal tone.
Okay, what does that mean exactly?
It stimulates the parasympathetic nervous system, which acts as the body's natural brake pedal. This stimulation slows down the electrical conduction, specifically at the AV node.
And the AV node is the electrical gateway between the top and bottom chambers of the heart.
Exactly. We call this a negative chronotropic or dramatropic effect.
Which is why we see it used for atrial fibrillation, or AFib.
Right.
Because in AFib, the top chambers of the heart are quivering chaotically, just firing off hundreds of rogue electrical impulses down toward the ventricles.
Yeah, it's a mess.
So digoxin doesn't cure that chaotic rhythm, but by slowing down the AV node, it acts like a strict toll booth operator.
I love that. A toll booth operator, yeah.
It throttles how many of those chaotic impulses are allowed to pass through to the main pumping chambers, which keeps the overall heart rate from just spiraling completely out of control.
Stronger contractions, but a slower, more controlled rate. I mean, it sounds like the perfect combination for a failing chaotic heart.
It really does.
But because this mechanism physically alters the foundational electrical gradient of the cells, the line between therapeutic benefit and a fatal arrhythmia is terrifyingly thin.
Yeah, digoxin is the textbook NTI drug. It sits right alongside things like lithium and warfarin.
Oh, absolutely.
But the part of the story that truly shocked me when I was reading the research is that for decades, modern cardiology actually got the definition of safe completely wrong.
The paradigm shift here is massive.
Yeah?
Historically, clinicians defined the therapeutic range for serum digoxin as roughly 0.8 to 2.0 nanograms per milliliter.
That was the gold standard target.
It was. If a patient's blood work came back at 1.5, their doctor felt completely confident they were in the safe zone.
Then the DIG trial happens.
Right.
The Digitalis Investigation Group trial, which was published in the New England Journal of Medicine in 1997, they looked at almost 7,000 patients with heart failure.
A huge study.
Yeah, and I was reading these results, and I have to admit, I'm kind of baffled. The trial proved that the drug does not actually reduce overall mortality.
No, it doesn't.
It does not help you live longer. So given how dangerous the toxicity profile is, I just don't understand why any modern doctor would choose to prescribe this over incredibly effective, safer drugs like beta blockers or ACE inhibitors.
Well, it is a question that gets debated in hospitals literally every day.
I bet.
But the justification lies in what the DIG trial actually did show. It didn't extend life, sure, but it drastically reduced hospitalizations for worsening heart failure.
Oh, okay, so it's about symptom control.
We are talking about severe symptom control. Picture a patient who is already maxed out on beta blockers in modern therapies, but they are still suffocating from fluid buildup. They can't even sleep lying down.
That's awful.
Or an AFib patient whose blood pressure is just too low to tolerate other rate control drugs. Digoxin keeps them out of the ICU. It offers a massive quality of life benefit for a very specific, highly vulnerable niche.
But the 1997 trial wasn't the end of the story, was it?
No, it wasn't.
Because in 2003, researchers published a post-hoc analysis of that exact same DIG trial data in the journal JAMA. And when they broke down the numbers, they found this hidden warning that kind of changed everything.
They did. They realized that the patients who actually had the best outcomes, the fewest hospitalizations, and the lowest risk had serum digoxin levels between 0.5 and 0.8.
Okay, wow, that's really low.
Very low. But patients whose levels were above 1.2, which remember was historically considered the perfect, safe mid-range, they actually suffered increased mortality, particularly women.
That is wild. The physical pill didn't change at all. But the medical consensus on what constituted a poison just shrank drastically overnight.
Exactly. The new therapeutic range was redefined downward to a tiny window of just 0.5 to 0.9 nanograms per milliliter.
Outcome data finally caught up with centuries of empirical dosing.
It did. And with the safe range shrinking to such a microscopic window, recognizing when a patient has inadvertently crossed the line into toxicity is, well, it's one of the most critical skills a clinician can have.
Let's talk about that, because if a patient comes into the emergency room complaining of sudden, bizarre visual changes, that is your first major clue.
Oh, yeah.
And medical students are often taught this really vivid historical theory to remember it. It involves the Dutch post-impressionist painter Vincent van Gogh.
Right. Late in his life, Van Gogh's paintings, like The Starry Night or The Night Cafe, are just dominated by heavy, brilliant yellows and these massive swirling halos around the stars and artificial lights.
It's his signature style from that period.
Yeah, and medical historians have proposed that he might have been suffering from xanthopsia.
Xanthopsia, right.
Which is a condition that causes yellow-tinted vision, alongside seeing physical halos around lights. And both of these are hallmark, classic symptoms of digitalis toxicity.
Obviously, we have to note for the listener that this is entirely speculative.
Oh, 100%.
There is no hard medical record confirming Van Gogh was ever prescribed digitalis, though, it was sometimes used for suspected epilepsy back then. Art historians usually just argue he went through a period where he really favored the color yellow.
The historical debate is endless on that one. But as a teaching tool, it is absolutely brilliant.
It really sticks in your mind.
If you want to remember the unique visual toxicity of digoxin, you just picture The Starry Night.
Yeah.
Yellow vision and halos around lights.
Right.
When a patient on digoxin describes those visual changes, alongside severe nausea, vomiting, lack of appetite, and confusion, you are looking at systemic poisoning.
So visual symptoms and nausea are the subjective clues, but the immediate next step is getting them on a heart monitor.
Always.
And this is where nurses and doctors get completely faked out by what they see on the screen.
Yes, they do.
Because there's a very specific ECG finding a scooped ST segment depression that literally looks like a Salvador Dali mustache. I've always heard people associate that shape with digoxin toxicity.
It is arguably the single most common misconception regarding this drug.
Really?
Yeah, that scooped ST segment does not mean the patient is poisoned. It is simply the digoxin effect.
Wait, then why does it create that specific shape if it isn't toxic?
Well, think back to the jammed cellular pumps.
The nightclub doors.
Right. The ST segment on an ECG represents repolarization, the moment the heart is electrically resetting itself for the next beat.
Okay.
Because digoxin is blocking the sodium-potassium pumps, those cellular ions are physically struggling to get back to their baseline positions.
Oh, I see.
That electrical struggle literally pulls the baseline of the ECG downward, creating that scooped, mustache-like appearance.
So it shows up in patients who are taking a perfectly therapeutic, non-toxic dose.
Exactly. It just proves the drug is in their system doing its job.
Wow. Okay. So a Dali mustache is expected. What does actual fatal toxicity look like on the monitor then?
True toxicity manifests as highly dangerous arrhythmias.
Like what?
For example, paroxysmal atrial tachycardia with an AV block.
Okay, break that down for me.
This means that the top chambers of the heart are firing at an incredibly fast abnormal rate. But because digoxin is clamped down so heavily on the AV node's toll booth, Those signals are blocked from reaching the ventricles.
Got it.
You might also see bidirectional ventricular tachycardia.
That sounds intense.
It is. It's where the electrical signal is so profoundly corrupted, it is literally ping-ponging back and forth across the ventricles in opposite directions on the monitor.
Jeez.
Yeah, so you had to combine those severe arrhythmias with the physical symptoms and then verify it all with a blood test.
But even the blood test can lie to you if you don't time it perfectly, right?
Oh, absolutely.
Because if a patient takes their morning pill, feels nauseous 2 hours later, and you draw their blood right then, the lab level might come back completely normal.
The timing is everything because the digoxin binds extensively to tissue, especially the heart and skeletal muscle.
Okay.
If you draw blood within the first 6 to 8 hours after a dose, the drug hasn't fully distributed into the tissues yet. It's still just circulating in the bloodstream.
So the lab is just measuring that free-floating amount.
Right, and it will give you a deceptively low or normal number, which completely masks a lethal amount of drug that's already bound to the heart muscle.
That's
You
terrifying.
must always draw the level at the trough, which is the absolute lowest point of concentration, ideally right before they are scheduled to take their next dose.
Okay, so drawing the level at the trough ensures you see the true baseline. But there is another lab value that we have to check alongside the digoxin level, and it introduces this massive paradox.
Potassium.
We need to talk about potassium, because I was always taught that low potassium is the biggest danger for a patient on digoxin. But the data shows that a high potassium level is actually the ultimate red flag for mortality.
This is the potassium paradox.
Mm-hmm.
And to untangle it, we have to completely separate chronic everyday toxicity from an acute massive overdose
Oh, okay.
because they behave in entirely opposite ways. Let's look at chronic toxicity first.
All right, lay it out for me.
A classic scenario. An 80-year-old patient on a stable, perfectly calculated daily dose of digoxin gets a severe stomach bug and becomes dehydrated. Or, maybe their doctor starts them on a new diuretic.
Right.
As a result, their total pony potassium drops. This is hypokalemia.
Okay, so in that everyday scenario, the low potassium is the driver of the danger. Why does a lack of potassium make the drug more toxic?
Because potassium and digoxin are physically competing for the exact same binding sites on those sodium-potassium ATPase pumps.
Oh, they're fighting for the same parking spot.
Exactly. If the patient's potassium drops, the competition disappears. Digoxin is left unopposed, so it binds much more aggressively to the pumps, heavily exaggerating the drug's effect.
Wow. So the dose didn't change at all, but because the potassium vanished, the drug suddenly grips the heart much tighter.
Yes, hypokalemia worsens the chronic poisoning.
That makes perfect sense for the slow, creeping toxicity. But what happens in an acute overdose? Say someone accidentally ingests a massive handful of pills all at once.
In a massive acute overdose, the biological mechanism flips entirely.
Really?
The sheer volume of digoxin floods the system and completely paralyzes the ATPase pumps all over the body. Not just the heart, but skeletal muscle too.
Huh.
Because those pumps are entirely disabled, potassium cannot be pumped into the cells at all. It gets trapped outside and leaks rapidly into the bloodstream faster than the kidneys can filter it out.
Which causes severe hyperkalemia.
Dangerously high potassium in the blood, exactly.
So the high potassium isn't causing the toxicity in this case. It's a massive downstream symptom of the pumps shutting down globally.
Yes. And we owe that realization to a toxicologist named Charles Bismuth in the 1970s.
What did he find?
He proved that in acute digoxin overdose, the degree of hyperkalemia is a direct predictor of whether the patient will survive.
Yeah.
He found that if a patient's serum potassium crossed roughly 5.5 milliequivalents per liter during an acute overdose, their mortality rate skyrocketed to nearly 100% without immediate intervention.
That is a staggering statistic.
It really is. The direction of the potassium abnormality tells you exactly what kind of poisoning you are dealing with.
Well, if a patient is in that nightmare scenario like massive acute overdose, potassium soaring past 5.5, their heart ping-ponging in bidirectional VTach, we actually have a highly specific antidote to save them.
We do.
I read about how they developed this antidote in 1976, and it sounds like absolute science fiction for the era. They didn't just, mix chemicals in a lab.
No, they didn't. Thomas Smith and his research team developed DigiFab, which was originally known as DigiBind. It was an incredibly early, groundbreaking use of biologics in toxicology. They systematically immunized sheep with digoxin derivatives.
Sheep.
Yes, sheep. The sheep's immune systems created specific antibodies to fight off the digoxin. The researchers then harvested and cleaved those antibodies into microscopic fragments.
So when you infuse those sheep antibody fragments into a dying, poisoned patient, they basically hunt down the free digoxin molecules in the bloodstream and bind to them.
Exactly.
They act like little molecular handcuffs, just rendering the poison completely inert.
That is exactly how it works. And the new digoxin antibody complex is highly water-soluble, meaning the kidneys can easily recognize it and excrete the handcuff poison straight out of the body in the urine.
That is incredible.
You just calculate the required number of antidote vials based directly on the patient's estimated total body digoxin load or their steady-state serum level, and the reversal of toxicity is rapid and profound.
The sheer brilliance of using targeted biologics to neutralize a 250-year-old plant derivative is just stunning.
It's one of my favorite stories in medicine.
The entire landscape of this drug requires such intense precision. I mean, we've seen how the Dali mustache on the ECG represents the cellular struggle of repolarization, not an actual poisoning.
Right.
We unpack the paradox where low potassium tightens the drug's grip in chronic cases, but high potassium acts as the ultimate alarm bell for massive pump failure in an acute overdose.
Which is so crucial to remember.
And we looked at how the 1997 DIG trial and its 2003 follow-up forced the entire medical community to shrink the therapeutic safe zone down to that tiny window of zero point 0.5 to zero point 0.9 nanograms per milliliter, specifically to keep patients out of the hospital without increasing their mortality risk.
And, all of this history and cellular mechanics matters deeply today because our demographic landscape is shifting.
Oh, so?
We have millions of older adults living with atrial fibrillation and heart failure, and their kidney function naturally declines with age. Digoxin is cleared almost entirely through the kidneys.
Which means a patient can be perfectly stable on their daily dose for years, but the moment they get a minor infection or become dehydrated or simply start taking an over-the-counter NSAID like ibuprofen for arthritis.
Their kidney clearance takes a subtle hit.
Right.
They haven't taken a single extra pill of digoxin.
Right.
But because their kidneys slowed down, the drug silently accumulates in their tissues day after day until they cross that invisible line from 0.8 to 1.2 nanograms.
And then they arrive in the emergency room with yellow vision and a failing heart.
Exactly. It requires vigilant polypharmacy review from every doctor, nurse, and pharmacist involved in their care.
We are essentially demanding flawless kidney function to manage a centuries-old plant extract in an aging population with incredibly complex medication lists.
That's a huge challenge.
It really makes you pause and think about the origins of all this. If William Withering hadn't possessed the exact right dual training to investigate Mother Hutton's family recipe for dropsy in 1775, would we have ever isolated it?
It's hard to say.
And considering how many other strange, muddy folk remedies were casually discarded by modern science over the centuries, you have to wonder, could there be other incredibly potent, undiscovered, narrow therapeutic index drugs hiding in historical texts, just waiting for modern biologics and precise dose titration to unlock their potential?
The line between a deadly poison and a life-saving cure is often just a matter of knowing exactly where and how closely to look.
Keep questioning the margins, and we'll see you on the next deep dive.